Hi, everyone, and welcome back to the next episode of TILLY. I'm your host, Marissa Zeppieri, and we are so excited to have you here today. TILLY is brought to you by the Lupus Foundation of New England, and on tonight's episode, we have Dr. Sean Lordan. He is the president of Concierge Physical Therapy in Sutton, Massachusetts. He is also a board-certified orthopedic physical therapist. So, Dr. Lordan, thank you so much for being here with us tonight.
Thank you. Thank you. Happy to be here.
I would love it if you could just kick off and just tell our audience a little bit more about you, your educational history, your work history, and your work with lupus patients and also those with other autoimmune diseases.
Sure. Yeah. Thanks for having me. And yeah, so I've been a physical therapist now for about 12 years, and I got my doctorate from Northeastern University and undergrad as well. And I've worked in pretty much every setting, and I've seen lupus patients in settings in home health. I've seen lupus patients in skilled nursing setting, in the acute care setting at hospitals, and in the outpatient setting, which is the type of clinic that I now own. I own a sports medicine practice, soon to be expanding to 2 locations. And it's physical therapy is an occupation that I love, and I love it because we really have an opportunity to help people of all levels of pain, whether it's chronic pain, whether it's acute or subacute, or if it's something autoimmune, like lupus or MS. And I think that we PT as a field has a lot to offer patients with SLE, and I'd love to dive into the details.
Absolutely. Well, we're really excited to have you here. A lot of people in our community deal with chronic pain, whether they're in a flare-up or if they're maybe not, having too much of a flare-up. It seems like it's there often for most people that have lupus and overlap autoimmune diseases. And I think for a lot of us, we hear like we have to take painkillers and prescription medicine. And of course, there's a place for that, but people may not be aware that PT is another avenue that they can try for chronic pain. So I know tonight you have a awesome presentation for us. So can you just tell us a little bit about that and tell our viewers what they'll be able to learn in the presentation?
Absolutely. And so, and you use the exact words, right? So physical therapy, and my whole philosophy is, I don't want patients of mine getting surgery, using pain medication, or any medication in general to mask symptoms. We want to hit those symptoms at the root cause. And that's what we do, and that's what good physical therapists do, is find that root cause of the pain and fix it. And typically that root cause is it's from muscle and joint imbalance, and muscles being tight, and joints not being joints being joints being tight as well, but joints not being able to move, right? And again, in lupus, you see a lot of arthralgias and joint pain, and tenosynovitis or tendon pain, and these are all things that, and as we were talking earlier a little bit before this, but PT can help with that. And anybody who's got the diagnosis of lupus should really have a PT on their care team, because PT is the person they should be consulting before they take all these meds and go down surgical paths or anything like that.
So when we're looking at your presentation, or maybe if it's not in there, you could explain this to me a little bit and to our viewers. If we're in a flare-up, or we're just experiencing symptoms and we have chronic pain, or we have acute pain, or if we're having symptoms, so now we're sort of in bed and we can't be as mobile as we normally are, that in itself also can lead to increased pain, correct? So it sort of creates like this vicious cycle. Am I on the right track there?
Yeah, and that's why it's so important to have a good relationship with with a PT, because if you're kind of in a relapse, or you're coming into a flare up, that stage is so critical, because you just can't do too much, otherwise you go right into a flare up. So that's really, you have to know where to go from there. And that could be a medical intervention, a medication type scenario, but we really want to keep those into smaller windows. You don't want to be medically managing with you know with the pharmacy your entire life. The goal is to get off the meds, at least for for us. That's what we try to do.
Awesome. Well, we're excited to see your presentation. So Dr. Lordan's going to actually share his screen with us, and I will hand it over to you.
Wonderful. Excellent. All right, so I put this little presentation together today, and I really wanted to focus on not just SLE, but just chronic pain in general. So when we talk about chronic pain, I think of, any sort of diagnosis like, SLE, but everything that comes with it, right? So the arthralgias, the muscle aches, the pains, the tenosynovitis, or the tendon aches and pains, and everything that comes down the line from, um, from having arthritis or joint pain for your, entire diagnosis and for your entire life, right? So what can PT do to help that, right? So first, what I want to talk about is what we look at in a clinic, right? So, and I'm going to dive into this a little bit, but physical therapists, at least in Massachusetts, are what we call direct access. So we really act like a physician in the fact that most patients come to us directly off the street, and they may just have knee pain or shoulder pain or, low back pain, but it's really up to us to decide whether or not it's something more sinister, or there's something a little bit more concomitant that's driving that's driving their pain. So, certain things that we look at, that I use to define, something that's maybe a little bit more out of the ordinary and something that could be potentially autoimmune would be fatigue. If somebody's telling me they've got poor circulation or their hands and feet get cold, sometimes that's, I think we call that Raynaud's phenomena. And then with lupus, there are three different phases, right? Or three different phases that at least I know of. So relapse, flare up, and remission. So when somebody comes in, the subjective history to me is so important in just listening to people and talk about their disease progression or their pain progression, right? So I've had low back pain, Dr. Lordan, for 2 years now, for 3 years, and it really gets, it gets awful for about 2 weeks, and it starts to get a little bit better over time. But I'm also I don't feel great for those 2 weeks. I don't feel well. And it just usually comes with kind of a myriad of symptoms that don't line up to a typical mechanical low back pain, and that being just a bend and a twist, or you lift something up heavy off the ground and twist, and then your back, quote unquote, goes out or hurts. That's a mechanical low back pain right away. But when I start to see, people complaining of poor circulation, I think of, females during childbearing ages as just a general, obviously it can happen in males too, but sort of as a general idea, it just starts to get my mind moving in that direction. That it might be just something a little bit more than, shoulder pain, knee pain, low back pain. Okay. So what does presentation of SLE look like in a, in a PT setting, right? So from what I've found, there are more serious complications in children. My personal experience hasn't been so much with SLE in children. It's more been older adults. But, the classic, the muscle aches, the joint aches, tendon muscular junction aches, or pains, right? So tennis elbow, those sort of things. At the knee, you got your patellar tendon, okay? And at the knee with the patellar tendon or the quad tendon, that can make walking really painful or really difficult. When you get into chronic tenosynovitis or tendon inflammation in your hands, there's little tendon sheaths, right? So there's sheaths right over each tendon at all of your joints in your hand. And what happens is over time, if there's enough inflammation, that inflammation it can be really deleterious to the joint, and it can start to break down those tendon sheaths and cause these funny things called, the swan neck deformities, or the ulnar drifts. The ulnar drift is typically seen in a progressive RA patient. But again, it's just got to do with that autoimmune, your body is fighting itself and creating and propagating more and more inflammation in these joints, and they start to get hypertrophied or ossified, and you see these huge little, they get, it's bone laying more bone, because the arthritis and that inflammation continues to propagate. And then you see the drift over the sides. So these are just long-term effects, and the goal is to get in to see a PT before any of this stuff happens, so you can get your muscles nice and strong, so they don't start to turn into what we see here on the page. Okay. And what I found in the elderly, you're seeing more serositis, pulmonary involvement, which can be really dangerous because, and it can be difficult to diagnose because, a lot of times it's very common, in a sick elderly patient to get a pneumonia as well. So, that the diagnosis can get a little bit foggy if there are other things going on like that. But good. Keep going here. So how does it look, right? So if somebody's coming in with SLE in my clinic, what am I looking for, and how does it change how I'm going to treat them, right? So um, what I can treat, and really what I own and what we all own as PTs, are the musculoskeletal symptoms, right? But I also need to know who else I need to have on my team in order to make sure that this patient does well, right? So my job is not only to get to the root cause of their muscle aches and pains, or your musculoskeletal aches and pains, but to also figure out who on the team is going to help us, win the ball game, basically. So, I really love to include a primary care physician at any level of anything that I consider to be autoimmune. And I also love, obviously rheumatology is a great key player here. But how does somebody come in my doors if they're coming directly off the street with these symptoms? How do they get there? What am I looking for? Right. So fatigue, I'm looking for constitutional symptoms rather. So fever, general feeling of not just being unwell, which is malaise, fatigue, and weight loss. So weight loss is kind of one of those yellow flags too for us. I always ask, have you lost more than 10 pounds in 1 month? And was it intentional or not, right? Because people can lose weight intentionally by, eating a great diet and eating a healthy diet and exercising. But if it's a 10-pound weight loss and they're not exercising, that's something that I start to worry about. Is there something else going on here? um, and you may even think cancer too. So sometimes I'll typically send that back to primary, and then we'll figure out oncology from there. We'll get some blood work. Okay. But again, I mean, during the COVID times, anybody coming in with a fever, they're going to be, they're going right back to their primary care. They're getting right out of the office, and they're not even getting through the front door. So, these are extenuating circumstances and crazy times. But anybody with a fever isn't, and we're talking a low grade fever, 99, 99.5. Most people with a fever of 105, 102, 103 aren't feeling well enough to come to a PT office. But those who constantly run a low grade fever, sometimes they just get used to it and they don't even know they're running a fever, which is, really, really crazy. But what else am I looking for, right? So what makes me think lupus, or what makes me think there's something just a little bit more going on than, the typical low back pain, knee pain, shoulder pain, right? So the butterfly rash, or really anything facial, so for a PT, we're certainly not dermatologists, but if I see somebody's got a rash on their face, in combination with the constitutional symptoms, I'm sending right back to PCP, or I'm just calling, a rheumatologist and asking if they can come see or if my patient can get in within 24 to 48 hours, at least for blood work. Okay. Um, and the rheumatologist and the PT need to work hand in hand, right? Because as we're saying, there's different stages, right? And within those stages, if I catch somebody right before a flare up and I know they're going into a flare up, I need to work with the rheumatologist to get them properly medicated so we can get through that flare up. And on the other side, continue what we're doing prior to, whatever exercises, whatever we're working on. And maybe it was just activity modification, and maybe it was just energy conversation, energy conservation techniques. But whatever that is, it needs to be continued through on the other side of that flare-up phase. Okay. And again, I mean, the weight loss of more than 10 pounds that typically, worries me a little bit, but I'll usually send that off to a PCP and just get some blood work run just to make sure we're in the clear. And I've included in this little chart here just some symptoms, obviously other symptoms of SLE. So beyond just the myalgias and arthralgias, there can be some, hypertension or high blood pressure, hematuria, which is, blood in the urine. You have general abdominal pain. These are things that, all in like you may, obviously hematuria is, something you would immediately go to or call your doctor about, but just abdominal pain, pain in the chest, if it's really not bad, you may not call your PCP. So that's why we will see some of these folks direct access, and we can really help. Good. And on to that. So what do we do to help? What can PT really do to manage chronic pain, right? So chronic pain management is really the PT's bread and butter, okay? Uh, and what do we do? The first thing we need to do, especially if somebody's in a relapse, is just symptom management, right? So getting to the root cause of the fatigue, the aches, the soreness, the arthralgias, uh, hitting the muscles that are tight, loosening them up gently, not going in there with, these hardcore massage tools, the Graston technique, none of that. That's going to be way too much, but just listening to people. And really at this, in a relapse phase, or, and I hate to say flare up because we typically don't treat too much in a flare up, but um, our biggest asset as therapists is our ears. We need to listen, and we need to engage with our patients at a level that they can engage back. And it may not be the exercise level that we want them to be able to participate in, but any exercise is moving in the positive direction. We want to strengthen during remission because that creates a higher baseline function. And so we'll go into that in a little bit. What is baseline and why is it so important? But the baseline, it's just, if you, and Marissa and I were talking about this before, before the podcast here. Um, if you sit in bed for a week and do not move on bed rest, you could lose up to 10 to 15% of your muscle mass. And that is not easy to get back. That could take 3 to 6 months to get back. Never mind a month of bed rest. Okay, so 1 week in a bed, 10 to 15% of your muscle mass. You just have to have a high level of muscle, of fast twitch muscle fiber power. And it's just got to be constantly trained as often as you can if you're in remission. So let's just, focus on that for a little bit. And really the technicalities matter. So how we strengthen, right? And you can't just go to the gym and, choose a weight, say, let's do, or a personal trainer and say, hey, let's do, I want to build up size, right? It really has nothing to do with hypertrophy or size. Those words are interchangeable, right? Because hypertrophied muscle is just larger muscle. It has to do with power, right? So those fast twitch muscle fibers need to be able to grip and need to be able to move fast and pick things up that are heavy. Because that's the muscle that atrophies the quickest, okay, the fastest. So how do you train for power? So when I'm training for power, I train lower reps, so probably between 4 and 8 reps. I'll do 4 to 5 sets sometimes, depending, depending on what somebody can tolerate. But the weight is typically going to be a little bit heavier than what you might be used to, right? So let's say, you're a female and, you leg press, let's say you leg press, I don't know, 200 pounds. Okay. And you're doing that for 3 sets of 10. Okay. So for a power exercise, I might say, hey, let's go up to 250. We're going to do four sets of 6 repetitions, but you're really going to try, when you move that weight, you're going to try to push it as hard as you can and then come back slow. Push it as hard as you can and then come back slow. So I'm looking for speed, right? So I'm looking for velocity of that activity. And that velocity is what builds those type 2 muscle fibers, okay? And that's what helps create a higher baseline so that when you do go into a relapse or you're in a flare-up, your muscles have the ability to bridge the gap. And then when you come out on the other side, you have enough strength and power to be able to, pick up your baby out of her crib, or, be able to do, pick up the groceries out of the back of the car. And it sounds, it sounds funny, but these are things that literally every day people tell me that they can't do. Okay. And it's more common than you think. And just It can be changed dramatically by just developing a good relationship with a physical therapist, a good PT. Other education, just skin management, and imagine if there was a rash component, which from what I understand, there often is. I think that dermatology can be in the mix as well. But activity tolerance and energy conservation are a huge piece of this as well. In relapse, you've got to be able to get the power exercise in if you're able, but you don't want to do. It's just that fine balance, and that's where maybe you're doing a walking program too, and doing 2 days a week of power training or whatever it is. But that exercise, the walking is so good for your body in more ways than one. You've just got to get that in. So, and then maybe you're conserving energy in other ways, learning breathing techniques, diaphragmatic breathing, that sort of thing. And again, if I've got symptoms, most people, you can tell if somebody's telling me that they've got, blood in their urine, or if I'm running, there's a lot of tests that we do musculoskeletally. We test reflexes. There's a couple different upper motor neuron signs that we'll test, Babinski sign, and we'll do Hoffman's and some other things. So if I think that there's any central nervous system involvement or any symptoms of stroke or anything like that, facial drooping, I'll go through the cranial nerve testing, and if there's anything positive there, I refer out right away. So what specifically do PTs do to help with chronic pain, in patients with really with any chronic pain, whether it's low back pain, shoulder, knee, foot, ankle, or an autoimmune disease? It's very similar across the board. The difference with the autoimmune disease is that we have to be careful with any intervention that causes an inflammatory cascade, okay? So dry needling is one of the activities that will cause an inflammatory cascade. But we know that. We want it to cause an inflammatory cascade because that's what helps break down those trigger points, those nasty little trigger points that are in the muscles. There needs to be a specific approach to everything we do and everything in combination, right? So if somebody's coming in relapse, the first thing I'm going to do is look at all their muscles and make sure that there's no tightness, there's no obliquities, and fix that first. So fix joint obliquities, fix muscle tightness. And I'll potentially go in maybe even day one with, needling some trigger points, but I'm not going to get in there with the Graston tool, which is the metal instrument, and start blasting away at the fascia. It's not going to help anybody because it's just going to create and propagate way too much inflammation, and the body, which is already upregulated to inflammation, and the inflammatory cascade is going to go wild. So we don't want that. But what can maybe a trigger point dry needle do to help, right? So instead of grasping the whole, thoracolumbar fascia or thoracodorsal fascia, maybe I just hit one or two trigger points and just release those and see how the patient does, and follow up in a day or two and see how that goes, okay? And maybe that in combination with some spinal manipulation might help too. And it's funny, we don't know the exact physiological effects of spinal manipulation, but we do know that they do help increase joint size, joint mobility, not joint size, joint mobility, and it helps relax nervous system tone around those segments that are manipulated. So that's a really strong, powerful tool that we have as PTs, if the PT is educated in that. Neuromuscular re-ed is just typically just training movement patterns that move away from the pain and into functional positions. Okay, squats, lunges, that sort of thing, but with proper form and after they've got appropriate muscle length to do the activity. And we'll talk about it in a minute. Aerobic exercise is really has been proven to be excellent for patients with SLE, and should be really a part of anybody's, if you've got the diagnosis, anybody's daily routine. Good. And what's the research showing about some of the benefits of aerobic exercise for for SLE, right? So looked at a couple studies here, and really wanted to kind of see what the research was showing in terms of how do they combine aerobic exercise and anaerobic exercise, anaerobic being power or hypertrophy exercise. But really what I found is a lot of focus has been put on aerobic exercise. And they're looking at 60% of a maximum perceived exertion. Okay. And when you talk about a maximum perceived exertion, what they used was the max heart rate minus age. And it's basically a rating of perceived exertion. And they do it, uh, based on this scale here. So if you're 40 years old, it would be 180 would be your max heart rate. So 60% of that um, is roughly 108. So, how does an Apple Watch help? I think if you're wearing any sort of wearable tech, that's a great opportunity to kind of really track and see, am I hitting my target, which would be 110, 108, but 110, 115 beats per minute, to get the effects of that walk, right? So, you really want to kind of pick a course if it's, too easy for you, pick something that's going to get you into that range. And the technology is so great nowadays, it'll give you that feedback. Um, but the study done by 10 in 2003 really showed that a lot of symptom improvement, not just symptom improvement, but quality of life improvement, right? So less symptoms improve your quality of life. And that's a really powerful tool. So they said no matter what their patients were doing, or these people doing the study, swimming, biking, running, walking, or hiking, they all had symptom improvement with the aerobic conditioning, which is a wonderful thing. So when I was trying to look for exercise, what are the benefits of anaerobic exercise? Basically, what I found is that there's no adverse effects. But I'm going to go into in detail in a little bit. Is that we know what exercise does, right? So it's going to increase your energy level. It's going to increase your fitness. It's going to improve your functional baseline because you're getting stronger, right? And it's exercise is just great for your brain and for your body, right? But how does it help patients with lupus, right? And in my opinion, and it's just my humble opinion, and it's just coming from anecdotal and case level evidence, is that once you get those folks much that baseline stronger, it doesn't change the process of the disease, right? There's still going to be relapse and flare-ups, but what it will do is it just makes your life easier because you're going to be stronger, and the aging process as you grow with this with disease is just going to be much kinder to you if you're stronger and you're taking care of your body both aerobically and anaerobically. And again, this study, 50 minutes a day for 3 days a week, getting up to 70 or 80% of max heart rate. So that could be, that could be a HIIT workout, and a HIIT high intensity interval training. But again, it depends where you're at. You'd have to be in a remission to be able to tolerate this. So, that's why the relationship is so important with your hopefully your doctor or PT and your healthcare provider to make sure you're not at a point where this level of exercise is gonna put you in a flare up. And lastly, there's a program called Walk with Ease, and that's through the National Arthritis Foundation. There were two different groups here. So they met, there's an in-person group and then just a walk on your own group. The in-person group met 3 times a week for 6 weeks, and exercise leaders just talked about just different topics related to exercise and, just a little bit of patient education. How does exercise affect arthritis? How does it improve arthritis? And, I know as a physical therapist that exercise is the #1 tool that we use to battle arthritis. It's the best thing you can do. And we know that the outcomes are there. Specifically, aerobic exercise is great because what it does is it pretty much, I explain it like it lubricates the joints, right? The more you can, and again, within reason, you don't want to be walking for 3 hours a day, or golfing every day and carrying a bag for 6 hours. That's going to be too much. But within reason, you want to do a fair amount of aerobic and aerobic exercise. So I think, if somebody's in remission, the perfect breakdown would be, 3 days a week of walking, 30 to 40 minutes or whatever activity you like, hiking. I wouldn't go jogging or or running. It depends on, how you're, where you're at in your physical fitness. But biking, swimming is great for your body and your joints. It's good aerobic exercise too. Walking, 3 days a week, 30 minutes to an hour. And I would say at least 30 minutes of exercise with weights 3 days a week as well. So I guess the direct, this study found that the self-directed format of Walk with Ease appears to reduce stiffness and fatigue. I can't imagine that the group format didn't help too, but it found that the self-directed format was a little bit more efficacious. Okay. So what I want to go into a little bit is just current practice in physical therapy and imagining what the possibilities could be if you combined really what the tools that we have at our disposal as PTs, dry needling, Graston technique when appropriate, spinal manipulation, aquatic therapy, cryotherapy, things like this. And we applied all of that, with our knowledge of the musculoskeletal system and exercise to a patient with a chronic disease or an autoimmune disease. And there really hasn't been that much research combining all of those techniques, those manual techniques for patients with chronic disease. But I know anecdotally again, and from a case study level, meaning, working with my own patients, is that it works really well to just help relieve symptoms, right? And if we can relieve the symptoms, we improve the quality of life. And again, we're relieving symptoms without medication, without dangerous surgery or cortisone shots, any of that stuff. So, this is the safest and the most, in my opinion, effective way to continue and manage, SLE or really any chronic pain disorder or disease. And again, I mean, we need to get better as a field, at least in the physical therapy realm, when we're looking at what we do for patients with chronic pain and really specifically patients with autoimmune disease and autoimmune disorders. Because, we've got all these new tools and tricks at our disposal, but we're not combining all of them and seeing how efficacious they are against, just exercise or placebos and things like that. I think it's, when you're selecting a PT, it's really important to look and see, it could be as silly as, where their board certification, well, this isn't silly, but, where they went to school and where their board certifications lie. But it really is important to find a practice that lines up with your goals, right? And specifically, you want to find practitioners that are really pushing their comfort zones and doing things that, not the average PT is doing. And that's dry needling, spinal manipulation, which is typically done by chiropractors. You don't want to go to the clinic that's just going to give you a hot pack, a couple exercises, a home exercise program, and say, see you in a week. That's, or, when you're going to do a 1 time a week frequency, that's, it's ridiculous. You're not going to get any results. You've got to put in the time and the effort, and you've got to establish a relationship with somebody. But again, I mean, combine all those things: dry needling, spinal manipulation, exercise therapy, massage, and education. I mean, the outcomes are going to be fantastic. What's the caveat? And this is why the relationship is so important. Staging. If you are in a relapse or right on the border of that flare up, a PT or, and you see a PT who says, okay, let's do 5 exercises, right? Or, and they could be the easiest exercise in the world, that could put you right over the edge into a flare up. Okay. And it gets really, really tough. So that's where the communication piece, and again, I'll say it again, our most important asset in treating patients with autoimmune disease is our ears. We need to listen. Okay. So conventionally, rest and medication. And again, I mean, there might be times that your flare up is so bad you can't get out of bed. But that's what we're predicting, right? We're expecting that, which is why you've been working so hard doing the exercise with the PT. And it's going to be tough, right? Because your goals, and I always start my plan of care by asking, what is your goal for physical therapy? And your goal may just be able to get through the next flare up. And that's totally fine. And that's totally normal. but that might take time. It might take 3 months of conditioning until you get to that flare up and you say, okay, I'm here, but it's going to be way, way better than it would have been had you not been conditioning from the get go. So, you know, at times we're going to have to medically manage in the flare up stage, and that's where rheumatology comes in, and specifically they know more about the medication piece, and how every body is different, and how they're going to attack that is really just individual. So just depends there. My education of the patient, might be some breathing techniques for stress reduction. Obviously, educating them not to smoke. There's been a high correlate with making flare-ups worse with SLE. Getting enough vitamin D, avoiding alfalfa echinacea, protection from the sun, and just reiterating the education piece that it's going to get better. We just need to get through this phase and soon get to remission. Why act now, right? So what can a PT do to help you today? So PT, in the very least, should be able to offer you some basic exercises and the basic premise of what your body looks like in space. So we call it a functional movement screen. So I'll do just a quick screen, see how you're moving. I'll look at a lunge, I'll look at a single leg squat, I'll look at a regular squat, I'll look at some shoulder mobility. And what's nice is that we can actually do this through the computer now a little bit too. I do love to get my hands on people, but now we're able to get at least a general movement assessment through the computer via telehealth. But that's the first thing that I address is just how are you moving? How can I improve your movement, and how can I fix obliquities, whether there's scoliosis, whether there's already arthritic type changes in the body, which I can tell from what we call exostosis, which is just the bony, if there's a lot of bone laid down on a joint, which you'll see in RRA or other autoimmune disorders. You see it often in the foot as a bunion. Okay, that's an advanced arthritic moment at the first MTP. But I don't want to get into too many details. But if you're not in an acute flare-up, PT is your go-to. You just have to establish a relationship with a PT, and at least have that person join your care team to get you to a higher level of baseline strength and function. And really, what do you have to lose, right? You really have nothing to lose other than getting the opinion of hopefully a doctor, another doctor, and getting them in your corner for when you've got you're going through that flare up or relapse. You want somebody else to be able to communicate with, and somebody especially who's not going to send you down the road of more medication and more surgery or injections, right? That's not what we do. We get you through the worst parts of pain without any of that stuff. Okay. And who should you choose? That does matter. And I went into that briefly previously, but you want to find somebody with a board certification in orthopedics or neurology as a PT. It's about 8 different, or maybe it's up to 9 or 10 now, different board certifications in physical therapy. You want to find somebody who knows what they're doing. Okay, and somebody with a board cert is, they've had to have practiced for at least 3 years or 4 years. I forget, it's a certain amount of clinical hours. They've had to take enough Con Ed, continuing ed, to be able to sit for a board exam, much like any of your specialist MDs. So your orthopedic surgeons, your oncologists, rheumatologists, these are all board certified physicians, and it lasts for 10 years. And every 10 years they have to retake the test. So they've got the new research. So, and the other piece is just you have to make sure the practice is convenient to you too. That matters, believe it or not. And if it's not within a convenient drive, especially in the winters, and I know Marissa's out there in New York, in Worcester, we get a lot of snow. So you got to be able to get your appointments. And if you can't get there, that's a problem. Okay. We offer the telehealth. I think telehealth is great, but it won't fix everything. You got to get your hands on people as a PT. It's important to keep your appointments, and you have to establish a good rapport. So find somebody whom you like, and if you don't like that person, fire them. It's okay. Find somebody who you get along with, and who you feel like listens to you and gets you. Okay. ask professional friends, colleagues, when a follow us fails, look at the company's Google reviews, right? And see if they're recent. Are people lauding this place, or are they kind of just saying, there's no recent Google reviews, or, there's a couple 4-star, if there's a 4-star review, that's just not a good sign, right? So that's not and in my opinion, a well-run practice. Any practice, PT practice should really have all 5-star reviews, and they should be, have patients, singing their praises. Um, Good. Questions, comments, concerns?
That was awesome, Dr. Lordan. Thank you so much for sharing that. I definitely have a couple of questions that I thought about as you were going through the slides. So first, I've had lupus for 20 years, and when I speak with a lot of physicians, we sort of hear this roster of doctors that we should be followed by. And sadly, I don't hear physical therapy a lot, especially in the area of chronic pain. So I don't think I'm alone in that. And I'm curious, so for people watching, would they speak to their primary? Would they speak to their rheumatologist and ask them, or would they just go to a PT directly if they want to try to handle chronic pain through these interventions versus like medication?
Yes, that's a great question, Marissa. So, it just goes back to, how are those relationships, right? So you can, in Massachusetts, and I think every state might differ a little bit, but in Massachusetts, anybody can come see a PT off the street, so I would just say to go directly to your local physical therapist if they've got, if they're highly recommended by friends and family, and if they've got a good reputation. Um, the other piece is if you don't trust the internet, or you don't have any friends who've gone to PT before, ask your local PCP, or ask your doctor. Your rheumatologist may know a PCP, but the primary cares are pretty good with, the PTs in the area, because they're sending out, aches and pains all the time to PTs, so they know who's good and who's kind of like doesn't get it. But those are very few and far between. But yeah, I would say, first just, ask a friend, and see if they had a good experience somewhere, and try that place if it's close. But you can go directly to a PT.
Perfect.
Yeah.
And the other thing I was thinking was, so a lot of like, even for me, I've never truly been in a remission period. I've had symptoms every single day.
Mhm.
So for other people that aren't technically in a remission, and we can't just jump out and do a Zumba class or go hiking for an hour. I know for me, I'd be in bed for a couple of days if I just, went from like zero to that. So I'm curious, what are things that people can do from home? Like, can they do exercises in bed? Can they do exercises in a chair? And I think, where a lot of us get tripped up is we see people working out for 30, 45 minutes, and we may only be able to do 5 or 7 minutes, but you know, are we still getting that benefit? So if I were to do 4 5-minute workouts throughout the day as I have the energy, am I still getting the benefit as someone who's doing a straight 20-minute workout?
Yes. So, and this is where it gets kind of tricky, right? Because, you want to see that heart rate elevation, right? But it depends, Marissa, on, what how you feel. And that's why it's so important to have somebody do a movement assessment on you, and figure out which body parts and which muscles need the strength the most. So if I did, let's say I did a basic functional movement exam on you through the screen, I would say, okay, this is weak, this is strong. Do these three exercises supine or lying in bed. Do these three exercises in the chair. And tell me how you feel after doing 10 minutes of exercise today. And if you feel great, maybe the next day you do between 12 and 15 minutes, and just say, you know what, Sean, I think that was kind of the, that's the cutoff. Like 15 minutes is enough. Like I started to really, the next day I could feel it. I had to take a day off, and that's where you start. And maybe that's okay. Between 10 and 15 minutes, that's where you start. And that's where it's, the energy conservation piece can't be stressed enough, because you need to be able to function and do your like live life, and that's important too. because the whole point of doing PT is to be able to live a higher quality of life, in my opinion. Beyond whatever, your specific goals would be. But it's just so specific, Marissa. And I think like I could give you 3 blanket exercises to do in supine or in sitting, but it just depends on how your body moves, and that would tell me, which exercise would be the most beneficial for you individually.
Okay, so that leads me actually to my final question is, because of telehealth now and COVID, if someone was not in Sutton, Massachusetts, are they able to work with you, and what does that process look like?
Sure. Yeah, absolutely. So the process would be as simple as just as calling the office and setting up a telehealth appointment. Uh, and really from there, what we do is, would spend, half an hour on the initial call and just go through, history, go through what's going on, and just do a basic movement assessment and see how you're moving. Right. And so again, like I was saying, some of those activities could be squats, could be lunges, just could be, anything that people, are having trouble with. And then from there, we'll build really not just an exercise plan, but a movement, almost like a movement strategy plan, right? And then you schedule follow-up sessions, and that's the most important part, is just seeing how much, especially if I'm not seeing somebody in person, is just seeing what they can tolerate over time. So I think almost more frequent follow-ups would be important via telehealth, so that you can monitor, how much exercise people are able to tolerate and what specifically is beneficial and what's not.
So for anyone out there that would love to work with Dr. Sean Lordan, you can do it through telehealth. And obviously this is another great option for us that deal with chronic pain or even acute pain, but a chronic pain, and which is so common with lupus. And if you could just share really quick your website or just contact information, I'm also going to put it at the end.
Sure. Yeah. So it's it's conciergephysicaltherapy.com. And my email is just dr, so Dr. Lordan at conciergephysicaltherapy.com. So if anybody's got any questions, they want to reach out to me personally, I'd be, more than happy to touch base and answer anything that I can.
Thank you. Thank you for sharing your email. That was very sweet. Also, if anyone has any questions, feel free to leave them in the comments below and we will go through those. And I just want to thank you so much for being here with us. It was some great information. I hope that everyone that isn't really familiar with physical therapy understands that there are other options out there to deal with chronic pain. And we know just when you're in so much pain, it affects every single area of your life and really lessens your ability to do just even activities of daily living. It makes them just so difficult. So such an important topic. Thank you so much for being here. The Lupus Foundation of New England thanks you. And I hope everyone enjoyed this episode of TILLY, and please come back next week for the next episode and we will see you soon. Thank you, Dr. Lordan.
Thank you so much, Marissa. I appreciate it.